Friday. It's just before Memorial Day. Isn't that cool? Welcome back. It's live. The doctor's in live with TOA. We're here. This is a familiar face. You've seen Dr. Snowden before. We talked about scoliosis before. We're going to have a pretty interesting kind of new topic today. Ryan has a lot more experience than I do, certainly. It'll dovetail nicely with the conversation we had with Will Carpenter and the robotic knee replacement stuff we did. Robotics are interesting technology, but we're going to give you some ideas about what robotics and navigation are in spine surgery and what they're not, okay? So before we get started, remember, we are both fellowship trained spinal surgeons, orthopedic surgeons, but we're not your orthopedic surgeons, so please don't take any of this information as medical advice. We're strictly talking about entertainment, education, and informational purposes only. So if you have a problem, you need help with something musculoskeletal wise, go to TOA.com. You can learn about us, you can learn about orthopedics, you can learn about your body, you can learn about all we do. Go to the media center down there. There's an archive of all the tips and tricks and even these episodes on that page. But we're here to help you. So without further ado, again, this is Ryan Snowden. Ryan is a fellowship trained spine surgeon. He's the future of TOA Spine. And we're going to talk something about robotics and navigation, right?
It's going to be great.
Awesome.
Yeah.
I got a little video up here too,
Perfect.
a little animation video,
Okay.
so we can kind of show people what's
that'd be
up. Anyway, so tell me about robotics and
Yeah.
navigation and spine.
So I think there's two parts. One is what's navigation and what's robots, because it's tough to have robots without navigation. And when people think robots, we think machines that are working for us. I think defining those will help us sort of figure out where we need to go with each conversation. So what is navigation first off? So navigation is using some sort of frame of reference to figure out where the patient's anatomy is relative to that frame, so we know where our instruments are in space, so we can use that to help define the patient anatomy, whether that's for diagnosis, whether that's for instrumentation. There's a bunch of different uses for it. So navigation is sort of us doing the work, but having some sort of extra information to do that safely. So I think that's navigation. That's important to
Now, why is that navigation important? Why is having that information important for those guys?
Yeah, absolutely. So that information is important, one, because not everyone's anatomy is the same. So when we're doing these sort of major reconstructions, maybe a revision surgery, the anatomy may have been altered. Pediatrics, so we talked about that a bunch last time. The anatomy is very different. It's a curvature, there's a bunch of rotation. The bony sort of pedicle, which is where we put screws, gets smaller. It gets really hard to find even just with x-ray. So navigation, which we'll talk about, makes that a lot easier. And when you get into talking about robotics, robot's not smart. It has to figure out where to go. Navigation comes in for that.
So the big key, two things, is making sure we get the hardware in the right spot where it's supposed to be. And the really important thing is that we don't hurt anything that we don't want to hurt. Like, we don't want to touch the nerves, we don't want to touch the spinal cord with the hardware. And so because things are in 3 dimensions, it can be challenging to find where we need to put these screws and stuff. When I started in training, it was all done by feel and knowing the anatomy. Kind of step up from that, we would get regular x-rays and take pictures, so 2-dimensional views of these areas, and hope that we had the parts in the right spot. Then we started using C-arm, which was live video x-ray. All of those it's been an evolution, and now we're using these computer-aided, augmented reality, almost navigation types of tools to help guide us where we need to go.
Yeah. So I think that's definitely the next step is sort of the navigation platforms.
Yeah.
And you're talking about sort of the X-ray, the radiation part, and not even sort of instrumentation safety, but radiation safety. So there's a dosing component to that. Talking about the C-arms, especially sort of pediatric scoliosis, using a ton of X-rays versus a low dose spin. We'll talk about the O-arm and those sort of things in a little bit, but using lower doses of radiation to do the same amount of work, and eventually, hopefully, what we end up with is MRI, which is no radiation that can do the exact same thing. Not there yet.
And that radiation safety has to do not only with the patients, but also with us.
Sure.
Because we're in the field, getting our hands and our face and our chest radiated all the time, and we want to minimize that exposure.
Yeah, absolutely.
Okay, so you talked about navigation.
Yeah.
So what about robots?
Robots are cool. So I think traditionally we think of robots, we think of something that moves, acts like a human with some sort of automation. So it does things automatically for us. We're not there yet.
Yeah.
So what we are really talking about is some sort of automated system that is guided by us to augment what we're doing, and allows us to either do it more efficiently, so a little bit faster, or a little bit safer. And really what we're talking about here is placement of screws. So robotics as it stands in spine surgery is largely for screw guidance. And that's when we talk about robotics specifically in spine surgery, obviously different with joints and these others, but that is exactly what we're talking about. We're using some sort of guidance system. In this case, it looks like a robotic arm to help us place pedicle screws in a safer, more efficient fashion, and we can kind of talk about the details. Theoretically.
Yes,
Talk about the details of that.
That's the goal.
That's the goal. You know, the question is, are robots going to replace us? And certainly that's not what has happened yet, and not even close to that. So it's a really interesting topic and some cool stuff coming out. But I think we need to separate sort of robots doing the work versus automation of some guidance, which is what we're doing now.
Yeah, we don't have Hal doing the operation for us while we're sitting in the lounge drinking coffee.
Right.
Yeah.
Right.
Okay.
Not.
Okay, so what do you want to talk about first?
Let's do navigation. I think it's a good platform, and there's maybe a little broader topics there. Yeah.
So I've got a couple of little short video clips, or one at least, that kind of shows the basic kind of what we see in the operating room and what we're trying to accomplish. This is a super simple animation. And basically, there's no audio here, so you kind of explain what's happening.
So this is called the O-arm. It's one company makes this. This is a 3D fluoro, so it's not a CT scan. Technically, there are some out there that are a true CAT scan. This is a fluoroscopic machine that sort of creates a 3D profile of the bone. And while it's spinning, there's some sort of reference frame that is attached either to the patient or the spine that serves as a reference point. And basically what we're doing then is triangulating the patient's anatomy to our instrumentation to figure out where things are in space. The instrumentations have sort of a navigated component to them, so they have reference bulbs that this is sort of the eyes in the sky there can tell where everything are, and it will use the different points of reference to figure out where our instrumentations are based on the frame and then the O-arm span. So
go ahead and do the second one, Casey, and we'll let that run while we talk. So that video was strictly just how we gather the information to teach the navigation system where the patient's body is.
Right.
And then we use this navigation and robotics system to try to help us sort through. So we're going to let this play. This is the robotic thing, but this here is the eye in the sky, as Ryan calls it, which is basically it's taking data from the patient and matching it with the O-arm. Mm-hmm. This is how we do it here.
So the navigation part. So
the navigation understands where we're going. So now the navigation is, we'll just let this play. Yeah. The navigation is, it's not pictures, it's not photographs.
Right.
It's computer generated representations in 2 dimensions, giving you a 3-dimensional view.
Right.
So we know within the degree of error where we're putting screws, what angle we're putting them in, how big they are, right?
Sure. Yeah, so it does give you a level of detail that otherwise plain x-rays don't. So you can see sort of size, dimensions, depth. Depth is a big one, especially when we're putting in screws that go from front to back, and so we're figuring out both, is it in a safe place, what size do we need? We can sort of maximize the fixation with those screws by doing that. And the detail of it allows you to put them in safer.
And there are several different navigation systems as far as how they do things. Mm-hmm. This is just one representative thing that we use here. Mm-hmm. But there are other systems out there, so we're not promoting a single manufacturer or anything like that, but this is the equipment that we have. And in your experience, how's the navigation been How has that been for your practice?
Yeah, so this is something that we use a lot. Doing deformity, we've sort of fitted into the workflow of how our cases work. It allows us to do a couple things. One is screw safety, so placing safely. That's a big thing, and there's some studies looking at that. And if I were to do it freehand or with X-ray, I can put them in much safer using navigation. And not only that, it allows us to do it a bit quicker, which makes a difference when you're in kind of an extended surgery. So, figuring out how to do everything efficiently is really important. And so by using the navigation, we're not looking for the anatomy as much. We're not trying to figure out, okay, is this in the right spot? Checking multiple X-rays. We sort of have our spot lined up, and we're ready to go and place the screw.
Yeah, you basically introduced navigation to me when you came. When I trained, we used eyeballs and feel, and then we used X-ray. And this is a game changer for me as far as an extra level of confidence and safety. It's not for every surgeon. Not every surgeon is really wired to be able to think like a video game in 3 dimensions. But for those who can pick it up, I think it really does make a huge difference. And I think it makes these cases more efficient too. Safer from the patient's perspective, but also just time more efficient. So I think it's a really good tool. It can go awry. I mean, you're relying on, I guess in these cases, infrared, but a frame of reference, a marker on the body that's supposed to be in a permanent place. But if you knock it out of position or something moves, now the frame of reference is off. And so it's not perfect. We do experience times when it looks like we're supposed to put the screw here, but really we're supposed to put it here because something got knocked loose. And so it takes a little bit of challenge to make sure you're always safe in the right spot.
Yeah.
That's an unnerving situation.
And well, I think that's the really important part. Talk about how you used to do it with feel and sort of X-rays. That is not a lost art. And if you don't know how to do that, you shouldn't probably be using navigation. You need to know what to do when the navigation gets thrown off, because invariably it's going to happen at some point.
Yeah.
And especially with big cases, multiple screws, you're working around the frame. Oftentimes it gets nudged a little bit, and the whole point of navigation is to give you a frame of reference. It's not to do your work for you, and so you need, we're checking constantly to make sure that what we're seeing, what we're feeling matches what we're seeing on the navigation, and so we always want to make sure those are right. Occasionally gets off, and then you adjust, and then so a lot of times you end up working the old school way and putting them in by feel and reference and X-rays, which is a perfectly fine way of doing it.
Well, I'm certainly glad. Yeah, it's definitely a perfectly fine way of doing it. I'm glad you said that, because you do get into a situation, and if people don't know the anatomy or don't have a backup plan, I'm in agreement. They shouldn't be using the navigation solely, because they're putting all their eggs in that one basket, and something can happen. I mean, the electricity can go out. So I think that's a wise comment there. So what else about navigation?
Well, I think there are a few other parts, sort of the long-term trends of where we're going with this. One is navigation using non-X-ray, so MRI capability is one thing that I think will be coming out down the road, which will save us from radiation at all. I think that'll be a big component. Not only that is sort of, okay, now we have the navigation component, what else can we do with that? And that's when we start to get into robotics and using more augmentation of what we're doing to do it. The other part is, we talked a little bit about augmented reality. And so what we're doing is we're looking at a screen. So we're using 2-dimensional images that are cuts of a 3-dimensional rendering of the patient's anatomy. There is some augmented reality coming out. It's in its sort of infancy right now, which is something that you're wearing, some sort of glasses, most of them that I've seen, and you're able to see the patient, you're able to see your instruments, you're able to see the field, and overlaid onto that is the navigation image. So you're seeing the 3D anatomy beneath you, as opposed to your sort of normal depth perception, and that allows you that, theoretically, will be able to allow you to place instrumentations without having to look up at the screen. That's one of the downsides of navigation, is you're looking down at the field, you're looking up at the screen, and sort of you're splitting your time, sort of checking and rechecking.
And I think that's where people have trouble. Some people just can't do this, and keeping things still and keeping things, it's a challenge. It's a skill. I think that the technology is very interesting. I know you've done some kind of research on kind of the outcomes. Let me just ask you about the navigation piece. How is the literature looking with regard to safety and effectiveness of navigation in general in spine surgery?
So the best way to put it is, if I am not using navigation, how accurate am I in making sure the screw goes in the right place every time? Best guys doing this forever, super expert surgeons, like accuracy of 93% is kind of what somewhere around that is what the literature will say. You use navigation, it goes up to like 98%, 99%. It's much, much higher. Again, there's always outliers, things get off. But it certainly makes you a safer surgeon knowing how to use it. And I think the literature in our biggest studies really support that. Which is
and I would bet money that the super specialists are kind of an elite category. The specialists that do a lot, they're probably lower than that on their baseline accuracy every time. And so the difference between their accuracy and navigation accuracy is actually bigger.
Probably, because these are averages. So the studies
right, so it brings the
studies.
average surgeon more closer to a subspecialty super surgeon as far as accuracy.
Right, and it probably,
and consistency.
Yeah, it limits the outliers, which are, just, sort of the anatomy is a bit funny. It's hard to tell your normal sort of whereabouts. Which happens, bigger patients sometimes, and sort of really, really significant degenerative changes. It's hard to pinpoint normal anatomy. This is absolutely a game changer, and sort of your accuracy rate goes up drastically by having that. Big difference.
Okay, so let's talk a little bit about robotics. We've kind of mentioned things, and the Mako robot that we looked at with Dr. Carpenter, the knee replacement robot. Basically, it was a big machine, kind of a robotic arm that the physician interacted with. He actually had to hold this machine and kind of using his body, it wouldn't let him go past where he wanted to go, but he was moving it around. Now that's a different type of surgery because they're cutting straight lines and they're not really worried about drilling a hole into the spinal cord. And so the robot technology is different, but kissing cousins.
Sure.
So tell me your experience with, because have you used more than one?
I've tried two systems. I've used the Mazor a fair amount at this point.
Yeah. So there's a
couple
navigation
systems, and they basically do the same thing. And at this point, it is screw guidance. So both of them have a robotic arm that moves in multiple different dimensions to get the pathway for the pedicles. The pedicles where we place a screw. Get the path lined up so that we can place instrumentation down the pedicle followed by a screw. That's sort of the basis of what it does. Again, it's how to do it safely and efficiently, but that's what these do right now.
And it's using the navigation data.
Exactly.
Except it's kind of taking out that human analog component to it, making it more digital component. The humans are not interacting, but it's using so the navigation is part of it, whether that's preoperative navigation and data collection or intraoperative. You're still using the navigation data set to guide where the pedicle screws go.
Right, yeah, so exactly right. So the robot itself is centered to the patient. So there's a frame of reference between patient, robot, and then instrumentation. So that's a big thing. And that's really important, is how do you make sure none of those are moving. And they've come up with some ways to work around that, usually by placing a little pin into the back of the sacrum, which is a really strong bone. So that holds things in place to give a really not a moving target. And then what you're doing is you're moving that guiding arm over the place where you're going to put the pedicle, and then passing instrumentation back and forth through that. In this case, usually a drill and some sort of tap, and then you're putting a screw in. That's very simply sort of what we're doing right now, and that's the main use of the robot.
So tell me now about your experience and your research about the accuracy, the safety of the robot as we know it right now.
Yeah.
Again, this is really new technology.
So we're still in sort of not quite infancy, but it's a toddler.
We're toddlers.
We're toddlers now, and so what we found is it's incredibly accurate. I think that's the one thing we can certainly say, that its ability to put you in the path to place a screw safely is incredibly accurate. 98, 99%. as good, if not better, than navigation in and of itself, because to some degree we're taking out a little bit of that human error with us moving our hands, doing all of the work. At this point, we are still putting the instrumentations back and forth to guide it through the cannula, but the arm is sort of seated. It's a fixed structure that is helping us guide. So you're taking out a little bit of the human error, and we know that you can put these in really accurately. The percentage difference is it is still slightly imperfect in that we're allowing, there's occasionally reference changes, and it's still software, it's still hardware. There are still the very rare complications where it's off for whatever reason. My experience is largely with percutaneous instrumentation, so I think that's where this really shines. And there are a couple of studies, they're not huge studies, so looking at small groups of people who had traditional percutaneous instrumentation. So when we say percutaneous, we mean little incisions through the skin, replacing screws without really cutting through muscle and dissecting down to the bone itself. So we're not seeing things, we're all doing this all through either fluoroscopy, which is the old way of doing it, and in this case we're doing it through navigation and robotics. The old way of doing it, we had a needle that had a space, or we could put a wire down the pedicle, so we created a space for the wire, then over that wire we drilled, we tapped, and we put the screw in. So looking at the accuracy of that compared to robotics, I mean, it's really night and day. Percentage of misses is much lower. Percentage of misses for percutaneous, 10%, which is not that much, you think, but 10% is a lot, and the amount of those that have actual issues because of that is relatively high. So that's the big thing. It's not that we miss a little spot in the bone. It's that there are nerves around that, and you can have issues from there. And so avoiding that is the big advantage, I think, with the robot. So that's where I've really seen it shine, is percutaneous instrumentation. It allows us to do these less invasive or minimally invasive surgeries where we're getting some of the improvement in the disc space and decompression from indirect means, and doing little incisions does make sort of that initial recovery a little bit better compared to some of the more traditional ways of doing fusions.
Have you noticed, have you discovered, and again, we're in our infancy or a toddlership, so is there enough data to say that the robot provides a better outcome than traditional surgery?
So that is where things really haven't leveled out yet. So I think when we look at outcomes are a long-term improvement. Yeah. So I think that's really what you got to look at is whether or not you have the robotic surgery in the hands of a good surgeon who's doing the right surgery for the right reason. The outcomes are usually pretty good. Robotics, what we're trying to do is make surgery a little bit safer and sometimes more efficient. Not always the case, and that's where we can get into some of this gray area. I think outcomes really haven't shown any improvement with the robotics yet.
So it's a right now anyway. It's a different way to skin the same cat. Exactly. Maybe a little bit more precise, but is the ultimate outcome 1 year, 2 year, 5 years down the road any real difference? At this point, we haven't seen any difference.
Right. Yeah, we haven't seen that bearing out in what literature we have. Again, it's not huge data sets yet, but I think there's enough to say, from just purely an outcome standpoint, doesn't seem to make a big difference.
It's certainly not any worse than standard
that
surgery.
is absolutely, you can definitely say that. It is definitely not worse.
And so the big question then is, because these machines are expensive, that cost the hospitals a lot of money and whatnot, is it a financially viable thing? I think that's yet to be determined. I think we're still in kind of Gen 1, Gen 2. The manufacturers would probably say different because they've been around. Robots have been around for about 10 years or 12 years, but you were still kind of in generation 1 of mindset. I mean, you're just basically the first era of residents and people coming out of fellowship that have really used this stuff extensively. And so we won't know for 5-10 years what's down the pike as far as technology and where we are now. So it's an interesting time in our lives. I feel very fortunate to have you around because you've shown me things that I never experienced in training or in working that have actually helped me be a better surgeon, and it piques my interest more. Yeah. I've never done a robot, I've never used a robot, but I'm interested in it just because it's a new technology tool, and I look forward to maybe you'll invite me to the operating room one day to do a robot. Now, once again, just remember, so spine robots are not doing the surgery for you, okay? It's really important for you to understand that. It's basically just a more precise way of putting in the screws, just like we do every day with our hands. Okay, it's just more precise, more reproducible. So where do you see this going?
So that's a good question.
The augmented reality is one
question.
thing.
So augmented reality is certainly one thing that may save, again, radiation time, efficiency, those sort of things. The long-term projections of what is this robot capable of doing is a real question. So the Mazor has the no-fly zones where the basically the drill stops. You're stopped from going here because there's something you don't want to cut into there. That may be the point where we get at some point with the robotics. We use a high-speed burr, which is just a little Rimmel drill to take off.
You were talking about the Mako.
The Mako, sorry.
Yeah, that's okay.
Right.
So that's
Mako.
the knee replacement
Knee
one
replacement.
that we looked at. That has the no-fly zones
So
where you can't force it to go where you don't
exactly.
want to
So the robot will stop you from going
Yeah.
places you don't want to go. That's certainly things that have been discussed, is creating those no-fly zones within the spine itself, so you can do your decompressions largely with the assistance of a robot. It takes away maybe some of the guesswork, allows you to do it a little bit quicker, a little more safely. There will always be this. I think there's always going to be the need for good hands,
Yes.
because the covering of the nerves is a really delicate tissue, and I just don't think we're ever going to get to the point where a machine can do that without us being there to sort of feel and guide that. Da Vinci, which is the other type of robot there's that used for more general surgery, is a very fine, sort of detail-oriented robot. I don't know that we ever get to that point in spine surgery where they're doing, surgeon's not scrubbed in. Surgeon is sitting at a control monitor doing the surgery with all robotic arms. I don't know that if we get to that point, it's a long way away.
Yeah, I think so too, particularly because we do kind of macro work. We don't do micro work. The advantage of the Da Vinci type system has been always that it's super magnified, so you're looking at very small structures really big, and the manipulators that they use work in very fine ways, and so they can do big operations or complex operations in the belly or in the chest with very precise things, but it's still kind of a three-dimensional thing.
Right.
We're kind of pigs in a china shop a little bit. We're putting big screws in
Right.
in holes.
Yeah.
There's big consequence, but it's not quite the same. So yeah, that would be really interesting to see if we could ever get to that approach. What else do you want me to know before we wrap it up?
I mean, those are the big things. I think robotics, there's a lot out there about robotics. There are people that advertise that they're robotic surgeons. I think, when you're talking to people, you want to make sure that they are well-versed in doing things in multiple different ways. I think that's really the advantage to this. It gives people who are good at doing what they do just one other way of addressing problems and taking care of people.
Yeah, I think that's really a good point. It's not a robot surgeon. The robot doesn't make the surgeon a better surgeon. Let me get this right. A surgeon needs to be a good surgeon to make the robot sing and do well. The robot can't make up for a bad surgeon or a marginal surgeon. And so it really does take wisdom and experience at this point to deal with it. Anyway, pretty cool.
Good stuff.
Pretty cool stuff.
Yeah.
If you want to, Casey, do we have the ability to post that video you put up on our associated with it? Can you put a link?
I will be able to link it for sure.
Okay,
Yeah.
so we'll go ahead and link the two videos that we looked at, the O-arm animation and then the other. It has some audio to it. They're both produced by the manufacturer of that particular system. Again, I'm not advocating or conspiring with that manufacturer. We don't have any professional relationships with those people other than we use their equipment. But it's an interesting video to look at to kind of give you a little bit of idea of what we deal with, at least in animation. What's next time?
We're off the air next week, and then June 11th, we'll be back with Anita Slaughter, who is a trainer.
Trainer at the Performance Center.
Yeah.
Yeah, so I'm going to be out next week, going to South Carolina. Yay! But Anita Slaughter is one of the trainers with our Sports Performance Center. She's pretty incredible. I actually met her happenstance. I was picking my dog up from doggy daycare, and she happened to come in. She saw TOA on my clothes and said, "Are you a doctor?" And I said, "Yes, I am." And we got to talking, and she is one fit woman, and she's very passionate about what she does. And I'm looking forward to that. I think she's a great add to our capabilities down south. Anyway, so at this point, remember, go to TOA.com. We can help you learn about your musculoskeletal problems. We can help you find a physician to help you. Don't let it sit. Do something about your problems. There's a lot of things we have to potentially offer to make you more functional and more comfortable. Go out there, get your vaccination, please. I got mine. Yeah, it hurt, but it was good, and I feel better. He got his. Other than that, go out, live your best life. Have a great weekend. Happy Memorial Day. Thank you to all those who gave of their lives for our freedoms. Take care.
Thanks.
See you in a couple weeks.